Today's guests are Melvin Pitz and Cornel Tol from the HPC-TI, short for Headache, Pain and Concussion Training Institute. They're on a mission to educate and empower healthcare professionals with cutting-edge, evidence-based strategies to manage headache, pain complaints, and mild traumatic brain injury. With a strong clinical background and a critical view on how care is currently delivered, they're pushing for a multidisciplinary and biopsychosocial approach that actually works in the clinic and beyond. Hi Melvin, hi Cornel.
Hi Kai.
Thanks for making it to the podcast, and we'll jump right in. So the first question that I have is, you prefer the term prolonged post-concussion symptoms over traumatic brain injury. And why is that? Why is this distinction so important?
So when we work with patients, we prefer using the term concussion over mild traumatic brain injury. We work in the Netherlands, so we prefer hersenschudding over or above lichttraumatisch hersenletsel for a specific reason, because not only our experience, but at the same time supported by evidence and literature, the term MTBI carries some weight. So in terms of nocebo, it can happen that people who hear that they have a mild traumatic brain injury, they think, oh my God, there's an injury in my brain, there's a structural damage, which is supported by literature, which show that people with PTSD or anxiety or chronic pain tend to have worse outcomes just by the diagnostic of MTBI compared to when they hear they have a concussion. The study I was talking about is by Iverson et al. In 2013, and that maybe if somebody is interested can look it up. And so this is why we use the term to be aware of nocebo and placebo, the term concussion. So framing is very important because it influences the cognition of the patient and can influence finally the outcome of the therapeutic process. So maybe some people remember the paper of Michael Stewart in 2017, Sticks and Stones. It was a big highlight where maybe as an example, you don't say to a patient, oh, you have a lower doses. No, oh, you have a normal curve of the back. So in that terms, you have to think when communicating with patients. So, but for the further course, in professional terms, we use the term MTBI.
All right. Yeah. Okay, and going back to PPCS, that's the abbreviation of the post-concussion symptoms. What are the diagnostic criteria for PPCS?
Yeah, well, the PPCS, which is short for prolonged post-concussion symptoms or persistent post-concussion symptoms, is described by Silverberg in 2023, and we follow this diagnostic criteria, and it is already been adopted in the Dutch national guideline established by the Federation Medical Specialists, Federatie Medische Specialisten. And concussion is diagnosed when two things are present. So first of all, which is the most important criteria, is that there is a plausible mechanism. Think of a fall or a blow to the head or blow to the body, where the head is suddenly accelerating and decelerating. Second criteria is that there are clinical signs present. Think of brief loss of consciousness, confusion, or post-traumatic amnesia. But these signs are not always present, which can make it more complex and tricky to diagnose. So if these signs are not present, we look further. We are looking for still a plausible mechanism in trauma, and at least 2 acute symptoms within the first 3 days, so 72 hours, like headache or cognitive changes. And 1 measurable impairment, for example, imbalance or eye movement testing. So importantly, and that is something I want to point out maybe some later point once again, we don't have to recognize, or we should recognize, that most people with concussions don't have loss of consciousness. About 90% of those patients never had loss of consciousness. It's just 10%. And this is very important to know. So Imaging, when conducted, is usually normal, and baseline testing is often missing because we don't know what the pre-trauma situation of these patients is. Mostly baseline testing happens in athlete sports, so they can compare, they have some references. So the interpretation of tests like the VOMS, which is the vestibulo-oculomotor screening tool, or the BES, where you test balance and cerebellar function, can be tricky, especially if someone had already existing pre-trauma issues. And to make it short now, if you're interested, look up the statement of Silverberg in 2023, since this is a somewhat complex topic when it comes to diagnosis of concussion.
Yeah. I usually tell our guests that you can mention as many articles as you want, because we'll put it in the transcripts for all of the listeners out there, so they can check it out or do the reading after listening to the podcast. So feel free to go crazy with the references.
We will. Maybe I forgot the last point. You asked about specific PPCS, so which is the prolonged version of concussion, and we have the general population. So people have at least 3 months prolonged symptoms after concussion. Then we have PPCS, and we have the athlete population. So when those people have 4 weeks or more complaints after concussion, we talk about PPCS.
Okay.
Yeah.
And what is the current state when it comes to diagnosing and treating those patients in the Netherlands? Like, where are the gaps according to you guys?
I'll take that one. Okay. Well, I think the knowledge regarding concussion and regarding multi-traumatic brain injury is going through a great development at the moment. You've got the new guideline from the Federation of Medical Specialists. They've added a lot of new good information, which wasn't there before. And when you look, before I came here yesterday, I did a dirty search on PubMed to see what did mild traumatic brain injury do on PubMed. And since 2012, they're really peaking in the amount of articles, and that's good. But the sad thing is, it takes on average 17 years for new information to drip through in general practice, and we aren't there yet. It was 2012 when it started peaking. It's 2025, so we need a few more years at the moment, but we are getting better, at least in the Netherlands, and I think outside the Netherlands as well. Treatments are getting better, and we don't treat it anymore as we did before. I think the question was where we are right now, right? The state.
Yeah.
The biggest gaps are there are many different types of patients, and we don't know yet which type to treat when they have these symptoms or that symptom. And at the moment, we are building there are 12 or 13 different pathophysiologies for prolonged concussions, and you need to treat that pathophysiology to get the patient better. And that's hard because you have to know everything.
Yeah.
And those are the biggest gaps, I guess, because you need to put in a treatable traits approach. And for that, you have to know every perspective you can treat. And yeah, we need patient profiles in the future to see, okay, this patient enters our clinic. What can we do? Oh, these and these symptoms are there. They've got this prognostic factors. Okay, we should do that treatment. That takes time, but that is probably the biggest gap at the moment.
Yeah. Good. Yeah, you mentioned those 17 years. I mean, that's one of the missions of Physiotutors, to shorten those 17 years to...
Let's hope so, because it doesn't only happen with concussion, but it suddenly does with concussion as well. But yeah, that's hard.
No, I agree. I think concussion is one of those topics you aren't taught at, or at least not, I wasn't taught it during my bachelor's or master's. So yeah.
No, it is increasing because at the moment I teach at the SOMT University as well. I give a lesson a day about concussions. A day is not enough because you need more time, but at least I know something about it. And my colleague Lucas does it at the other university as well. So the basics are being treated, but not. You need more information than that. One day is not that.
Yeah.
Not.
All right. And why do you think so many patients are misdiagnosed as having whiplash instead of concussion?
Yeah, well, I see 5 key reasons when answering this question. And now that I'm aware of what a concussion is and the diagnostic criteria, I think back in my time as a bachelor and when I finished my Master of Manual Therapy, I still couldn't treat those patients properly. And I thought, why is that? I did 3 years of education and put so much effort in it, and those patients won't get better. So and now I think, okay, I understand, because there's so much overlapping symptoms between WAD, so whiplash associated disorder, for short I call it whiplash, and concussion. So think about headache, dizziness, neck pain, fatigue, brain fog, sleep disorders, visual issues, and so on. So whiplash and concussion can have exact the same symptoms with some nuances, of course.
Yeah, important to when you discuss this with patients, don't use the word whiplash anymore, because that's a really nocebo effect. So we tend to call it post-traumatic neck problem. You've got a trauma with your neck, you have a problem. So even that could be a nocebo. You hurt your neck after you fell down, because whiplash is really like people tend to stress right away when you tell them.
Yeah, good. And so second point is maybe when you look at the history, there was a strong focus on whiplash-associated disorders when the car boom era started. So more and more people were able to afford the car, and more accidents were rising, and the registration of accidents and what happened with the people after the accident. So that was in the 1930s, and the rise of legal processes became more and more relevant in the 80s and 90s. And in terms of science, we have the Quebec Neck Pain Task Force, who focuses highly on the whiplash-associated disorders. So we have this classification from grade 0 to grade 4, right? And so that further solidified it. In contrast, concussion awareness lacked. So maybe about around World War I, World War II, we have shell shock phenomenon. You can look it up on YouTube. Then later on, we got NFL and NHL related interest in concussion research, but it was decades later. Yeah. So if there's no visible injury or loss of consciousness, clinicians often focus on the neck because it is maybe more visible, more palpable, and brain injury is invisible and maybe more abstract. Yeah? And number 3 is lack of standardized screening. There's a lot of evidence about the problematic of just pure diagnosis. And we have Silverberg, we have the Amsterdam Consensus, we have the Berlin Consensus. Depending on the country we live in, the region we live in, the diagnosis and registration systems, and so on. So the pathway is still extreme varying, and especially in first-line care. Yeah. And sometimes clinicians tend to label complaints like, okay, I know about whiplash, and there is a slightly more tendency to orthopedic vision on complaints, because everybody knows what the orthopedic problem is. So specialists, but also physiotherapists and general practitioners, tend to tell the patient, oh, the scan is perfect, clean, you have a whiplash, because you have been involved into a car accident with acceleration, deceleration. And another one is limited training. What Cornel mentioned, a complex situation with a complex patient. And what you experienced and I experienced, we did a master degree, and maybe a weekend or two, we focused on the neck in terms of after accidents or whiplash. But what about concussion? So we never heard of it. Well, friends, family, but yeah, that's it. And so not all professionals, by far not all, are trained in recognizing this phenomenon. And so chances are high it will be missed.
No.
Time for our sponsor. Transform your physiotherapy career with a Physiotutors Premium membership. Enjoy unlimited access to masterclasses, research reviews, and clinical tools, all designed to enhance your clinical skills. Join a global community of over 100,000 professionals. Our platform supports multiple languages, making it accessible to professionals worldwide. Don't miss out on this opportunity to excel in your practice. Visit physiotutors.com/membership and start your free 7-day trial today.
Okay, let's move on and talk about the prolonged symptoms. What are prognostic factors that people develop prolonged symptoms after concussion?
Prolonged symptoms. There are a bunch of prolonged symptoms which have been widely researched, and partly they differ from other musculoskeletal problems, but partly they're overlapping. So think about pre-existing mental health issues. PTSD, depression, anxiety are not the best factors to have when you experience concussion. ADHD, earlier concussions, earlier neck and shoulder complaints, high initial symptoms, mostly measured by the post-concussion symptom scale, which is not validated in our area. We have the Rivermate. So we talk about if more than 39 points, you will higher likelihood to develop post-concussion or persistent post-concussion symptoms. The having simultaneously cognitive and vestibular impairments. If you're a low adapter, imagine like you have a glass of water which is 50% filled. Yeah, you ask 10 people and some say, oh, it's half full, and the others say it's half empty. So those people tending to say it's half empty tend to have lower health outcomes after a therapeutic process, but also tend to have higher chances of developing PPCS. Yeah. Low social support, very important. So you have friends and family who don't understand you. What's your problem? You look fine. So what's going on? Are you still having complaints after 4 months? It can't be. Or maybe the employer is not supporting you and is pushing. Yeah. And one of the most important factors is delay of time to presentation, which has been researched by Prettil in 2022. He worked together with specialized physiotherapists, and they looked at more than 1,000 patients after concussion who visited or contacted the clinicians between 0 and 9 days and 10 and 30 days. And if you visit a clinician post-concussive after or between 0 and 9 days, you have 2 times higher chance of being discharged earlier with positive outcomes compared to the group who present themselves after those 10 days, let alone after 30 days or even longer. Yeah, and that is very important to be conscious of that, because when we shift to more knowledge about this topic in diagnostic, in information and management, I think people really can make a difference as a therapist. And this could have an enlarged socio-economic impact for our whole society if guidelines would propel the aspect of go to the physiotherapist, maybe a specialized one when it's possible, after concussion within 1, maybe 2 weeks.
Yeah, sadly at the moment they're still telling us to wait for 6 weeks. Wait for 6 weeks and see if it recovers, and that doesn't work out.
Yeah. I forgot one. Being female is not so advantageous. So you have a higher likelihood to develop persistent symptoms.
Okay, you kind of mentioned, or there was a good segue because you mentioned the role of the physiotherapist. According to you, according to your opinion, how should we rethink the role of physiotherapy in the management of concussion or post-concussion symptoms?
Well, I tend to see a lot of patients who've already visited another physio before me.
Okay.
I don't know if that's a good thing or not, but sadly, a lot of patients get the wrong advice beforehand. And that's a sad thing. Mostly I tell them that it was enough advice till the moment. I don't want to put down my other colleagues because it will create a nocebo effect for physiotherapists in general.
Yeah.
And we'll build on that. What I hear is that a lot of physios actually have 2 kinds of approaches at the moment.
Yeah.
It's like, okay, rest, just like the guidelines mentioned before, and build up gradually. do it calm, no exercise because exercise can increase their symptoms, so you shouldn't do that. That's one approach. And the other approach I hear is the chronic pain approach. Okay, we need to accept that this is your problem, learn to deal with the pain and those kind of things. And that's sad too, because that isn't the case. You can really treat it in a different way. And that also happens in the Netherlands at the moment. The clinics are starting to change their way. They're not treating it as chronic pain anymore. They're really treating it as a concussion. So it's really different. And I think we should rethink the role of the physio by addressing the pathophysiologies which are underlying in the persistent concussion symptoms. And if we know about those, then we can really treat it. Some people come in with vestibular disorders, some can come in with visual disorders. We can't always treat it ourselves, but we can screen on it. If you see a visual disorder and you know, okay, this is not for me, this is for the neuro-optometrist or for another healthcare professional, we could really have an important role in that. So I think it starts with having the right knowledge about it. And if we know the right knowledge, we can do the right thing. And most important is what we do in the first phase, as Melvin already mentioned. If we see patients early, we can educate them on what's right. And that really works out because educating people in the first week will really prevent in the biggest group prolonged symptoms. Definitely.
Yeah, as a follow-up question, maybe I'm actually surprised that people do see a physiotherapist. I would have expected that they see the GP, and the GP says, "Yeah, whatever." Like that the GP doesn't refer to physiotherapist in the first place.
Yeah, true. Most GPs tell to take rest for 6 weeks, and there is a trend in changing that because some GPs I know, they tell, okay, you have to do things, so you have to start doing walking and make sure that you don't increase your symptoms, but do something like that. And if you experience neck problems, go to the physio. So the patients without neck problems, they tend to not go to the physio. But with neck problems, then the GP would say, okay, for the neck, you can go to the physio. But neck problems is just one part of it, one symptom. There are a lot of symptoms. And I think if physios would address those two in the first phase, that would really prevent a lot of people from getting symptoms. Yeah.
If the physiotherapist with this awareness and some kind of self-confidence would be proactive and takes a case from the practice and tells with the content knowledge he has, look, doctor, so and so on. I have a client here. He has had a concussion 6 weeks ago. Understand that you sent him to me. I see this and this. And I know that the guideline is advocating 6 weeks, no physiotherapy. But my knowledge is that this and this and this is the case. Would you be able, have time and interest to talk with me about that? So that we get a role of updating other health professionals, especially general practitioners, and sometimes maybe even neurologists. Yeah. So pick up the phone, call them, go along, talk to them, ask for chatting with them. And the worst thing which can happen is no, and the door stays closed. The best thing which can happen is the mind is switching and something will happen in favor of the patient and a future patient. And I think the physiotherapist should develop this confidence to take this leading role to change the switch in the minds of other healthcare professionals.
Yeah, and I think we really need more physios specialized in concussion because I think when you look at both our schedules, we would love to see patients in the first weeks or days of it. Looking at the schedule, it's impossible at the moment because patients have to wait for 2 months to see. It's like, crazy, okay, you're specialized, so I should go to you. And that's why we're educating people that these patients should be able to see a healthcare practitioner specialized in concussion earlier because it will prevent them from becoming persistent. And that's a problem at the moment. And GPs should address that things too. A lot of patients, when they get the right advice in the first phase, they wouldn't even need to go to the physio.
Okay, let's go a bit more into detail about neurophysiology or what's happening after concussion. What is the neurometabolic cascade described by Gisa and Hofda. And why is this essential knowledge for physios?
It's a hard one because mostly during the course I take about an hour to explain how it works.
Yeah, probably in simple words, that would be good for me as well.
Well, in the end, we actually tend to let the physios educate each other on how you would explain it to a patient. What's really important is a knowledge of the neurophysiology of the brain, how a neuron works, how an action potential works, and those kind of things. In short, the neurometabolic cascade has two phases. The excitatory phase, that's the phase when you get hit, like in the moment itself. And what happens at that moment, in your brain, you've got gray and white matter, and the white matter has another density than the gray matter. So it gets pulled and stretched in between, and that pull and stretch actually creates an enormous influx of sodium and potassium.
Right.
So that's what happens at the excitatory phase, the stretching and pulling, sodium and potassium influx. And afterwards, you get the spreading and depression phase. And what happens is a huge energy crisis because more sodium and potassium than ever before has entered the cell, or it's gone to the outside of the cell. It has to be pumped back by the sodium and potassium pump. Every time that happens, it takes ATP. So that you get an energy loss. Not only that, a lot of calcium has entered the cell as well, and the calcium takes a hold of the mitochondria. And now you can't create energy anymore with the aerobic glycolase, but you have to use the anaerobic glycolase. So normally you can create 100% energy, and then only 10% of that 100%, adding even more to the energy crisis. So that's a problem. And what also happens in the spreading and depression phase is the blood flow is getting restricted to your brain. And it's a protective mechanism because you don't want to bleed out if something's bleeding, but nothing's bleeding. So you get even less ATP to the brain. So you've got three things adding to the energy crisis, and that's what creates the people's symptoms. And the energy crisis is at its lowest after 3 to 7 days. And that's why it's quite logical that people tend to experience more symptoms after 3 to 7 days. At the beginning, they're like, no, I'm kind of okay. And then the energy crisis actually starts building up. So that's what's roughly happening during a neurometabolic phase.
Yeah, thanks for your explanation. Yeah,
he's very good at it.
I agree.
So during our course, he's the one taking the lead about this topic. What I want to add is that when you look at those graphics, of course, it's mostly animal studies, which this information is based on. Well, it's enough when 10 to 20% less ATP is present to have these severe symptoms. When we look at medium or severe traumatic brain injury, 40 to 50% is enough to be fatal.
Yeah.
So we're not talking about 100% of 80%, no, 20% and more to have very severe problems and complaints. Yeah.
And I don't think we should address second impact syndrome. I think that's too deep.
Well, but in terms of return to play later on, I will nudge it maybe, but
it a bit,
yeah.
Okay. Yeah. So thanks for the technicalities. Very interesting. Why is it that usually monodisciplinary approaches like manual therapy or just exercise, why do they fail?
Well, if you look at MTBI and the patient which presents themselves in the practice, they don't only have neck pain or only headache, but it affects multiple systems. Well, think of cognitive complaints, vestibular problems, emotional and physical complaints. So that makes it more complex, of course, for the healthcare provider, especially in the private practice setting. So single treatments, miss key symptoms or causes. So cognitive and emotional issues need addressing alongside physical therapy. And this is some limitation you not only see in the concussion population, but also in the persistent neck pain population, in the persistent low back pain population. So it is challenging for healthcare professionals, especially for the therapist working in the private practice, to address all those symptoms and working alongside those physical complaints. So what we need is a holistic and multidisciplinary care, which improves recovery chances, but are difficult to organize. due to personal, sometimes personal and logistic reasons, and a lack of insurance company facilitation, I would say. So you could say it is a systemic and a systematic problem.
Yeah, lots of patients have to find their own way through the landscape. That's hard.
Yeah.
And that's why I know they in their area, me in my area, are trying to create multidisciplinary first line treatments, because mostly that happens in the second line. And we really need to, don't forget the occupational therapists, neuro-optometrists, all those people, they can play a role in this treatment, and you really need to know what they can do, and they need to know what you can do, because otherwise you won't get far with these patients.
And which disciplines would you say are or need to be involved in the process?
Yeah, Cornel was already anticipating.
Yeah,
No problem. Go on. Since it affects multiple systems, you mostly need a variety of care, like neurological help, when you think of cognitive fatigue or headaches, vestibular care. So it can be a specialized vestibular therapist or a manual therapist with this knowledge. So in terms of balance and dizziness, visual disturbances, so then you need a neuro-optometrist or an orthoptist, somebody who is able to look functionally at the eye health, of the health of the eye. If you have cervical complaints or jaw complaints, you need a manual therapist or orofacial therapist who is able to address those problems. Of course, there's a high risk of the presence of psychological problems. Then you need a psychologist or psychotherapist, or even more. Think about anxiety, PTSD, and depression. And at least you have autonomic dysfunction or problems. So think of heart rate variability or orthostatic intolerance. And then you need a physical therapist who's able to detect that and address that. Yeah. So what makes it even more complex addressing this is that the symptoms often interact across the domains. So imagine if you have visual disturbances. You can get headaches, you can get neck tension, dizziness. So the neck and the vestibular and the visual system are working so closely together, and they're dependent from each other. If you have cervical dysfunction, you can have balance problems, cervicogenic dizziness, or visual tracking issues. And last but not least, if you have anxiety, it can exacerbate cognitive symptoms, sleep disturbances and pain perception.
And it does a lot of clinical overlap. Clinically, it's really hard to distinguish between post-concussion symptoms and post-traumatic stress disorder or anxiety, because symptoms can really be the same in a lot of people. That's hard.
Yeah, absolutely. So that's why it's so important to differentiate and what is overlapping and what was going on pre-trauma. Yeah, how did you step into the trauma? What was in your package you were carrying when it happened?
Okay, let's talk about diagnosis and decision making. Which clinical tools, according to you, are absolutely crucial in concussion assessment, but also monitoring?
Yeah, when I hear this question, what immediately jumps into my mind is the Buffalo concussion treadmill test. Well, it is a gold standard test for detection of autonomic dysregulation.
Let's call it dysautonomia.
Dysautonomia. Okay.
Dysregulation. GPs will be on fire.
Okay. Yeah, and so it's a physical exertion test to determine the subsymptom threshold where people can or the patient can learn to start being active again on a way which is not harmful in terms of no severe symptom aggravation. And before that, what sometimes is missed is the active stand test. This is some kind of modified version of the tilt table test, which is done in hospitals for detecting orthostatic intolerance. Think of POTS or hypotension. This one is very important. So another one is the Rivermate post-concussion symptom questionnaire, especially in our area. It's validated. On the other hand, we have the post-concussion symptom scale, which is like the Rivermate. We have the BES, so the Balance Error Scoring System. We have the VOMS, so vestibular oculomotor screening. The BIFS, which is a questionnaire about visual functioning, and it stands for Brain Injury Vision Symptom Scale. And so on the psychological domain, we have, for example, the HATS, which is the Hospital Anxiety and Depression Scale. Most physical therapists know this one. And screening for PTSD with the help of the PCL-5. And last but not least, recently there has been an update within this concussion domain. There are 2 new questionnaires. We know the catastrophizing scale from other musculoskeletal problems. So we have the PCS-CS, looking for is there someone who is catastrophizing because of the concussion symptoms, and we have the FMA, which is for detecting fear of mental activity.
Time for our sponsor. Are you a physiotherapist or healthcare professional aiming to elevate your clinical practice? At Physiotutors, we offer a comprehensive suite of online courses designed to enhance your skills and knowledge. Delve into specialized topics such as running rehab from pain to performance, where you'll learn to improve your patient's running efficiency and reduce injury risks. Or explore central sensitization in patients with persistent pain, providing evidence-based strategies for effective pain management. Each course is meticulously crafted by leading experts, ensuring you receive up-to-date, practical knowledge applicable to your daily practice. With flexible, self-paced learning, you can access our courses anytime, anywhere, fitting seamlessly into your busy schedule. Join thousands of professionals worldwide who have advanced their careers with Physiotutors. Visit physiotutors.com/courses today and take the next step in your professional development.
All right, so yeah, there's quite a lot of clinical tools and questionnaires that you guys will use in practice, but which makes sense if it's a complex case, of course, and a lot of dysfunctions are involved or are present in a patient. Okay, if you look at things that can go wrong in terms of red flags or pitfalls that physiotherapists miss, what would you say are those?
Well, most of these physios don't see the patients really soon. So it's not that some physios are like sports physios and they see these patients on field. Then you can do a SCAT5 or SCAT6 at the moment to screen if it's safe to go on. But mostly we see these patients later, so not so quick. I think it's always important to start with cranial nerve screening. So do those tests every time a patient get in. Just perform them. Better safe than sorry. It doesn't happen a lot that you see a problem with that, but you should do it. Mostly these patients go to the ER first or to their GP, and when it's necessary, the GP or the ER performs Canadian C-spine rules to see if the CT scan is necessary, but in most patients it isn't. So yeah, do the cranial nerve screening. That's it. It should be sufficient in most cases, and just listen to the story. If there are any general red flags or the D's and the N's we use in the Netherlands, I don't know if there's like everywhere, right? So you should screen for those, and if you can't make it click, then you should refer.
Okay, yeah, let's move on to treatment. So I think the most interesting part. So could you maybe describe how a treatment or the whole treatment process looks like, and how do you decide what you would prioritize first if there's a lot of symptoms? Like, do you start with cervical disorders, vestibular disorders, psychological, cognitive? What's the how do you prioritize in your treatment?
Yeah, I understand what you mean. Well, some things are typical we do, some things aren't. I think one of the typical things we do is empathic listening. You need to hear the story of the patient, but that's I think a general physio thing. First, listen to the whole story, not only what happened during the concussion. Of course, that's important, but you need to know what happens in the patient's life, what has happened before. Ask for all psychological things. Ask for their social situation, how's their financial status, and those kind of things. Because that's the first step in the first session, is just really listening for 20, 30 minutes and asking questions to get a complete image of who is the person in front of you. I think that's really important, and many patients with concussion feel like they're misunderstood, like they get the colleagues who say you're like it's not real what you're experiencing, those kind of things. So I'm glad listening is important. And then in the first session, I really start to educate what I just told you about the neurometabolic cascade. I tell the patients about that, and a lot of interns I see, and they can treat my patients, and I just sit beside them, and they're like, "Wow, your patients really know a lot." And I'm like, "Yeah, they should," because I educate them for like 30 minutes the first session about what is going on in the brain and what happens, and that creates such an amount of awareness in these patients, and that helps already for reducing the symptoms. So that's always important to do that. If I address that, I start with addressing, okay, what kind of underlying pathophysiologies are here, and a lot of patients experience insomnia or sleep problems, and then we do CBT, cognitive behavioral therapy for insomnia. We do relaxation training if their sympathetic nervous system is too high. We learn how to do the training if we did a Buffalo concussion treadmill test, how to do the exercise, how to do the subsymptom threshold program. We give simple dietary advices. We want to make sure that they eat anti-inflammatory, because inflammation always happens after an injury. It's the same with a concussion, so anti-inflammatory diet works really good. We tend to give them a structure using the traffic light system. So that's the first part of the treatment, and then it's a lot of education and a lot of work for the patient. But I believe in, if we can give the give it to the patients back how they should do it, that actually gives them a lot of control and reduces symptoms right away. If they are able to do that, then we'll go search for, okay, are there any visual problems which we can address, or vestibular problems, or neck problems, or psychological problems, or those kind of things. And it's really a shared decision-making approach, because when the patient tells me, okay, I've got a headache, okay, let's see what things influence this headache. Let's treat that first. So if there's a visual problem causing the headache, okay, let's treat that first. And during the treatment, the symptoms tend to change. Okay, so the headache's gone. Okay, what's not? Yeah, okay, yeah, headache. No, I don't have a headache anymore. It's more vestibular problem. I experience vertigo. Okay, let's check the vestibular system. What's wrong in that area? And like that, we just try to cut out everything step by step. What's most important for the patient. And in the end, it becomes harder, because sometimes you can't find anything. Like, I don't find any vestibular problems. I don't find any visual problems, no cervical problems. What should I do? Sometimes we choose for exposure in that case, because these patients aren't used to doing things anymore. And then we start to do exposure therapy. And that's also hard, because that takes lots of steps as well. Or we do acceptance and commitment, or cognitive behavioral therapy prone to their problems. So you need to know a lot. And it's not like a standard treatment. It's treatable traits approach, I always say. Actually, like every physiotherapy approach, I think. Yeah, you need to address the problems you find.
Maybe if I may add, I can imagine when we talk about this, it all sounds slim and slick and smooth. But often the practice can be very challenging, of course, even for us. So if you ask a question about prioritizing which treatment first, so at best you have several treatment options available at the same time, and you can conduct it together with the patient if he's able to endure it, because it takes time and energy and conviction. But if we see a patient with a high level of anxiety or depression, so sky high scores on the questionnaires, or there's an evident PTSD, maybe a simple one, okay, we tend to push them to a psychologist or a psychotherapist, even though we have waiting lists, of course. But we need to address those severe mental health problems first, because if that is not addressed, they disturb internal neurological systems. Yeah, because the autonomic nervous system is affected by how you feel and how you think. So, and then we're not even talking about complex PTSD. So then I have to make a decision. Do we continue in the first-line practice, or are those mental health disorders so severe that we have no chance of making one step at all? So please go to a trusted healthcare professional in the mental, emotional domain. So at best you have a network so you can refer to, but that are some considerations we have to do in clinical practice, because we don't have a cookbook. So if we do this, you get better. If we do this, you get better. No, what fits at the moment for you? So one size fits all, that's not possible.
No. And how do you guys decide when a patient is ready to progress?
We can use the evaluate measurements, of course, Melvin just mentioned. But I actually evaluate every session. So I tend to ask people about, I always say, you've got 3 things you do in your life. We do sports, we do social and personal things, or social and personal activities, and we do work and studying. That's like in a nutshell what people do. Where are you in those things? If they tell me like, yeah, I'm with sports, I'm doing the steady state cardio, but I want to play soccer again. Okay, let's see how we can progress in that area. In some patients, you need to work with the law of supercompensation. Just go through it, take some rest, go through it again, take some rest. In some patients, we use exposure for that, but it's just the normal process of physiotherapy, I guess. And yeah, you can use the evaluated measurements for that, because you can do a Buffalo concussion treadmill test. The second session, for example, you give the patient advice how to do exercises. Yeah, we need to know if dysautonomia is gone, so we can retest it a week later, and we can do it a week later again, and a week later again. In practice, that's hard because I can't see a patient every week.
Yeah.
So I try to teach them how to do it if it's possible, and then they can do it themselves and just tell me how the test went the last time they did it. So that's a way to do it. How do you do it, Melvin?
In terms of
Evaluating if progress, when do you progress to the next thing?
Yeah, in terms of evaluating, I stick to a greater plan, I would say. So in athletes, I want to see them every week for re-evaluating their exertional limits. So and what their aerobic capacity is with the help of the Buffalo concussion treadmill test. So they get the instruction, they do what I say, and 1 week later I test them again. So in athlete population, in general population, I see them every 2 weeks for reassessing the Buffalo concussion treadmill test. If I do vestibular visual training, I expect within 4 to 6 weeks first clinical relevant changes. So I will reassess them maybe about 6 weeks. Yeah, and the Rivermate Post-Concussion Symptom Questionnaire is validated for higher time frames, so 6 months mostly, but I tend to conduct them together with the patient mostly after 3 months. Yeah, so that there are a few examples in the practice how I handle this.
Yeah. Do you guys ever use the traffic light system that is common for other pathologies? Like you give an exercise, they do it, they feel worse afterwards. So you tell them like, look, this is not what you should experience. And if they stay at least on the current symptoms, then it's maybe orange and they can exercise a bit more.
We use that a lot. And we want patients to have symptoms. It sounds a bit strange, but most physios tell patients you can't have any symptoms, but if you train your visual system or your vestibular system, you should experience symptoms. So we use that a lot, and when they get back with after a week or 2 weeks, we'll be like, okay, how are the exercises hard enough? Does it still increase your symptoms? If it doesn't, you need harder exercise because then it gets too simple. Yeah.
And there are patients which have difficulties feel what their body tries to tell them. They have maybe not this body-mind connection some people are talking about. And then you have to recalibrate together with the patients to find out what is your body telling you in which situation. And then the traffic light system is sometimes not enough. You have to make an in-depth analysis. We call it signaleringsplan in Netherlands, but it's a signaling plan. So this is something the occupational therapist uses sometimes for sensoric integration problems. So auditive stimulus is too much, light stimulus is too much. Talking with two people at the same time, I get overwhelmed. And so these are all signs or things a patient should be aware of. And why is that is one question. But what do I do with it? What is my coping strategy with it? Do I go on pushing through symptoms? This is mostly not what we want. And if that is clear, then we can go back to the traffic light system when it's calibrated, and then we can use it.
Can you guys maybe both share or quickly share a case where you feel like your approach really made a difference?
Quickly, okay.
That's why I said it,
yeah. There's one case, I changed the name. It's Michael. He's 30, male, and he was on vacation in July 24. And they were with friends on vacation in Spain on a rooftop bar of terrace. And the floor broke and they fell 2 levels down. They crashed and it was all over the media, and so he suffered a concussion. So he flew back to the Netherlands, took 2 weeks rest, and got back to work. He was a technical draftsman, and when he came to me, he already had the complaints for about 5 months. And he was working 30 hours. And from Wednesday on, he was knocked out. He was in the red, if you're talking about the traffic light system. So in free time, he was pedaling and weightlifting. Weightlifting was surprisingly good. Pedaling, not so good. Got dizzy and visual disturbances. So chiropractic care he chose for, in first instance, every 3 to 4 weeks on the upper cervical spine, did temporarily give some more mobility, less pain, but it came back.
Yeah.
So he was stuck. The intervention consisted of reassurance, psychoeducation, giving him light at the end of the tunnel. We have a plan for you. That is a timeline. That is a content. And we will help you. We are your safety net. And that was the moment he opened his eyes and said, okay, for the first time I hear and understand what my problem is and where I have to go to and what I have to do. I have tools. So I asked him, do you want to be expert of yourself? And he was an active guy. He was highly educated, so that's helping, of course. I said, yes, I want to. So everything I told him, he did. So I was a grateful patient. I was grateful therapist, of course. And he needed a structured return to work protocol with the traffic light system. At the same time, he needed an occupational therapist. And for his cognitive disturbances, he needed a neurocognitive rehabilitation therapist to do multitasking, concentrating during conversation with two persons, focusing on screen. So we had several domains we were tackling with several healthcare providers. And we did, especially for his pedaling, so where he did overhead movements, we did vestibular visual rehabilitation. And after 3 months, these complaints were gone, luckily. And hands-on were myofascial techniques on the upper cervical spine. So after 4 to 5 months, he said, I'm 80% better. I can work 38 hours and I can sport, but I still have to be aware. I have to stay connected with my body. And this is maybe the key message. So if you have post or prolonged post-concussion symptoms, the journey doesn't end when the therapy ends. You have to stay in connection with yourself. And one thing at the end, maybe what was very challenging was that he developed some kind of good old days bias. So everything was so much better in the past. As if he had never complaints before, neck pain, headache, whatever, never tired. So he was over-idealizing the situation before the trauma.
Yeah.
And that did not help him because I want to go back. It was so good for me. That was my perfect life. No, even that life had flaws.
Yeah.
And that was something which was very challenging. Yeah.
Okay, thank you.
Yeah.
Was that short enough?
I think that's fine.
Please,
Go ahead.
Get emotional.
Maybe this is a story about a few weeks ago. I had a boy, and he was in my waiting list, and it was like he needs to be seen quick. It's an athlete. Before that and that date, he needs to join a game. Otherwise, he wouldn't be able to join the Dutch team, the Dutch national team.
In what sport?
I can tell because then you can. Then
Okay. Okay, go ahead.
You could probably know who it was, but yeah, I shouldn't tell the Toronto mechanism either. Then, so the boy got some advices like take a rest. You had a concussion. You don't need to do anything. And I was just listening to his story, and I was like, you know, the narrating voice in your head, which happens when you see a patient. I was like, I don't think he had a concussion at all. So, and this is hard because what we as a healthcare professional tell our patient has a real effect on how they handle your things. And so I listened to his story. I explained to him what the neurometabolic cascade was. It was already 7 weeks ago. He didn't do anything. He stayed in a dark room and those kind of things. And I said, okay. I told him the story. So maybe you had a concussion. It takes 22 to 45 days for the energy crisis to resolve itself again. It's been 7 weeks, so that time is past. And so you should be able to do things again because the concussion is gone. It's over. So my proposal for you is go train tonight. Send me an email tomorrow morning. How it went. Go to school. Do everything. Just live your life.
Sure.
The day after, he sent me an email. Training was good. It was fun. A week later, he sent me an email. I don't have any symptoms. Is this okay? Is this normal?
Yeah.
And I think those cases are fun as well because really people tend to think, what is actually happening right now? I don't have any symptoms. Why didn't I do anything the past few weeks? And I think we should be aware of those nocebos as well as GPs, as physios, because someone can have a knock on their head with whatever, but if they don't experience any symptoms, you can still have concussion, but advising them the wrong thing can really be harmful, and people tend to act to it even if they don't have any symptoms.
Yeah, thank you. Interesting story. Yeah. Hey, last question about treatment. How do you guys decide when a patient can return to work and also when they can return to sports?
Okay, so whether or not it is return to work or return to play, we assess several key domains. So first of all, the symptoms. In best case, the patient is asymptomatic and is back to baseline. And there's no significant increase in complaints during activity. So maximally 1 to 2 points, but that's okay. Then we look at cognitive functioning, so attention, memory, speed, multitasking, which is mostly performed by the neuropsychologist or the cognitive rehabilitation therapist. We look at vestibular oculomotor system, stable balance, smooth visual tracking, fixation, and so on, with VOMS and BES. Physical tolerance with the help of the Buffalo concussion treadmill test. But also psychological readiness. So does the patient see himself going back to what he wants naturally? So is there still are there still signs of anxiety, depression, or PTSD? It should be cleared at best. And the last domain is the task force demands, so task-specific demands. So on the work field, we should look if the patient is able to meet the cognitive and physical job requirements, and in the sports domain, handles drills, agility, contact without symptoms. So, but specifically in sports, we clinch to the Berlin Consensus Statement from 2023. So there are several well-described steps. So after concussion, symptom-limited activity within first 48 hours. Light walking, light cycling, nothing more, nothing less, relative rest. After that, step 2 is light aerobic activity based on the outcome of the Buffalo Concussion Treadmill test. After that, if you're 24 hours asymptomatic, continue to step 3, which is sport-specific drills only when asymptomatic after 24 hours. Non-contact training is the next step, together with the absence of complaints during the VOMS test and the DANA or impact test. Those are 2 tests which are done in a neurocognitive setting. So if that is okay, go on to full contact practice. If you're asymptomatic after this drill or after the training for 24 hours, you're ready to return to play, but progress daily unless symptoms return, or if worse, return to earlier stage. And what is important to note is, due to the neurophysiological features of the neurometabolic state and the inherent natural course, we do not advise return to play in contact sports within the first 3 weeks because of the heightened risk of a second impact syndrome, which is a special topic, short SIS, but it's nothing you want to have. And even if a patient says, I feel good, do the test. Test them in those VOMS, a Buffalo Concussion Treadmill test, neurocognitive testing. This should be fine, even if the patient says, why? I feel fine. No, do it, please. So that's very important. And
you can be asymptomatic, but the neurometabolic cascade has happened. Well, even if asymptomatic, you should at least wait 3 weeks.
Okay.
And specifically to close this topic, when it comes to return to work, we have some tips. So always start with the home office situation. Little task, gradually build up in time and work demands. So for example, reading mails, answering phone calls, doing some housework, assignments, and typing on screen. So if you can tolerate, if the patient can tolerate this 1 to 2 hours without significant symptom exacerbation, that's good. Then gradually re-entry to work with reduced hours and reduced task, so demands. Then start with 2 hours max a day, and after that day you have a buffer day, so you have free to reconsider what is happening with to me. Is it okay? Is it not okay? And if it's not okay, you have a buffer day. You can take what is needed to maybe rest, maybe light activities, so to adjust. Very important is no pressure, no deadlines during the return to work in the first phase. Talk and coordinate with the employer and the occupational therapist. In the best situation, those 3 communicate with each other, to adjust the situation to the patient. Use pacing, screen breaks, control light exposure, insert short movement snacks, what my colleagues tend to say, by walking, for example. And if 1 week was successful with this strategy, you build up in hours. And if you're able to work 8 hours, then you tend to build up in work demand and tasks, higher cognitive tasks, tasks in a row without a break. Stress and deadlines are the least factors we want to add before full return to work.
Right, I have 2 questions left for you guys. First one is maybe a quick one, but after all that we've been talking about, what do you think? Or what's your take on high impact sports like boxing or American football? Should they be forbidden, or I think it's maybe a personal opinion.
Yeah, I don't think those $1 million industries are gonna change because of my opinion. But yeah, we know that repetitive impacts and multiple concussions can eventually lead to chronic traumatic encephalopathy, and that's not something you would like, I think. So you see changes in America, like for children, they do flag football, pulling the flags from your thigh. So these are good changes, and there are regulation changes in children, but not in adults yet. And yeah, when you look at what it can lead to, it would be better to get rid of some things, but it's fun to watch,
Yeah, I agree. What about soccer and the heading?
Yeah, it depends because
I've done a lot of headers in my soccer career.
they're doing research at the moment, and I had a discussion with Edwin Goedhart a few weeks ago. He's the sports doctor of the kid.
Yeah, familiar name. Yeah.
And he said, when you teach children to do a good header, eyes opened and brace themselves, the chance of concussion is low. But people who aren't good at heading, well, shouldn't head because the chance of concussion becomes higher. So you could say something about techniques. There's something to say about that. But the research isn't far enough for us to put a conclusion on that yet.
Okay, and the last one. What's one myth that you guys would like to bust around concussion or prolonged post-concussion syndromes?
Well, a good one, very good one, because we hear it all the time, especially in practice. Avoid all screens and stimulation. Minimize all sensory stimuli. Wear sunglasses and earplugs, and take enough rest in bed. So the truth is, controlled reintroduction or cognitive activity is part of recovery. Relative rest is okay for maximally 48 hours.
Yeah, bit of the same story like in the past when people had like back pain and they were in the hospital for like 4 weeks. Exactly. They were told to lay down. Yeah. Exactly. All right. Okay. We've touched on a lot of topics. Is there anything that we haven't talked about that you guys feel like we should really add this to the podcast?
Well, we can be here for hours or day. So I think for now we really got through the basics. I think.
I want to do a call to all physiotherapists to take initiative and create networks. I think the future will look like what we see in the Netherlands. We have a low back pain network. We have a knee network, a shoulder network. We need a concussion network where specialized physical therapists with commitment take part in it, and where we have networks with other healthcare providers. So those people have a safety net and know where to belong after a concussion. And the general practitioners and specialists know to where refer to. This is hardly needed. And I think this will spare a lot of frustration for the patient in first instance, but also for the healthcare providers. Yeah.
Okay, and at last, where can people find you if they want to know more about you guys or if they want to reach out maybe with a question?
Well, LinkedIn is always fine. We tend to respond, quite fast on LinkedIn, I guess.
Yeah, I'll put the link in the transcript for sure. So,
And we have our own website, which will be linked to, I guess. We are always available. If you have questions, whatever, contact us.
All right. Okay, with that being said, Cornel and Melvin, thanks a lot for your time and for your knowledge.
Thank you
for inviting us.
Thank you very much.
It was a pleasure. All right, and to all of the listeners out there, as always, thanks a lot for listening to this episode. And if you want to listen to this and other episodes in your own language, including German, French, Spanish, Italian, Portuguese, and Dutch, download our free Physiotutors app. And additionally, you can access the transcript, like mentioned, and infographics, and also find more useful physio content. And if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts as well. Consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll talk to you in another episode. Bye.